Thank you, Bhavati, for hosting this. Hello and namaste to everybody who has actually joined us, both on Zoom and also on our Facebook, the MeHeLP Facebook page. Namaste and good evening to you all. It's my great pleasure to host this second webinar in our second webinar series on promoting mental health literacy in Kerala. This particular program, this particular webinar is actually about promoting mental health literacy in tribal communities with special reference to Kerala in this context, but we will also try and cover the tribal communities in India from a general perspective. I am Raghu Raghavan. I'm a professor of mental health at the Montfort University in Leicester in the UK. And I lead a mental health literacy project in urban and rural communities based in Kerala at the moment, funded by the UK Research Councils, the Economic and Social Research Council, Arts and Humanities Research Council, and the Global Challenges Research Fund. So people who have actually joined us through Facebook page, welcome you as well to this program. And we would normally talk for about 45 minutes, and there is we can actually raise questions through the Q&A the chat on Zoom, and then we would have a wider discussion with the audience in relation to the topic of promoting mental health literacy in tribal communities. I have great pleasure to invite Dr. Narayanan, the medical director of the Vivekananda Health Mission at Attappady in Kerala, to this webinar. I'll introduce him formally in a minute. Before I do that, let me just say a few words about the mental health literacy project in India called the MeHeLP India. This project is based in Kerala, as actually Seb said, and we work with two NGOs, the Mental Health Action Trust and the MeHeLP, which is based in Calicut, and the MeHeLP Foundation, which is based in Kochi. And our India partners also include the Tata Institute of Social Sciences based in Mumbai, NIMHANS in Bangalore, and Logadami Theatre Group based in Kochi. Our UK partners also include, apart from the Montfort University in Leicester, UK partners also include Loughborough University of Loughborough University, which is also based in Leicester, the Middlesex University in London, University College London, and Excavate Theatre Company based in Nottingham. We promote interdisciplinary work, and we have work across a range of professions using theatre, film, and creative arts as a research methodology to promote mental health literacy and mental health awareness. So in this particular project in MeHeLP India, we have worked with urban and rural and tribal communities in 4 districts in Kerala, in Palakkad, in Kozhikode, in Malappuram, and in Ernakulam. So we have collected well over 240 narratives, talking to mental health users, their immediate families, and also people in the neighborhood in terms of their experiences, issues, their expertise, and how they seek help, and other kind of issues that they may actually experience. And based on that, we used a theatre-based engagement with those communities in February last year, and from then onwards, because of the pandemic, we have curtailed our face-to-face engagement. We have actually gone more the digital engagement. We also hosted a film festival towards the end of last year, called the MeHeLP Film Festival, to increase mental health matters awareness among the general public in Kerala. And why are we focusing on Kerala? Because this is actually based on the rationale of the Mental Health Survey of India in 2017, which focuses on a higher prevalence of mental illness in Kerala, and also higher rates of suicide within the Kerala context. So our aim is actually to construct social, cultural, and lived experience narratives in understanding mental distress and mental illness and how people actually seek help. So mental health literacy is actually an important concept here. It is actually a Western concept, but we are not actually trying to implement the Western concept within the Indian context at all. We want to we want to try and develop a culturally developed notion of what is mental health literacy in the Indian context. So what is mental health literacy? Mental health literacy comprises of 6 different pillars or 6 components. It is our ability to recognize specific disorders or different types of psychological distress. It also refers to, secondly, knowledge about risk factors and the causes of mental illness. And thirdly, it looks at knowledge about self-help interventions or helpful models. And fourthly, knowledge about professional help that is actually available, that people could actually access. And fifthly, it looks at attitudes which facilitate or promote the recognition of distress and mental illness. And finally, knowledge of how to seek mental health information. So low mental health literacy is associated with more stigmatizing attitudes, as well as increased delays in help seeking and access to appropriate treatment and other helpful modalities. So that is what we mean by mental health literacy, and that is where our work is actually focused on this research project in promoting mental health literacy. Now I have great pleasure to invite our distinguished guest to this discussion, Dr. Narayanan, who is the medical director of the Vivekananda Health Mission based in Attappady in the Palghat district in Kerala. In many ways, he has actually pioneered the work in Attappady in terms of healthcare for the tribal communities. And that is the reason why we wanted to actually hear his activities and how he started the whole process and the kind of lessons that we can actually learn in terms of how we engage with the tribal communities in terms of mental health dialogue and seeking help. He is the Chief Medical Officer and Trustee of the Swami Vivekananda Medical Mission in Attappady. He's also the State Vice President of Deshiya Seva Bharati in Kerala, and also the Director of the Vishwa Shanti Foundation in Kochi. He is a medical doctor with a DCH qualification, and he has been working in Attappady for a number of years. He came to Attappady in Palakad district in Kerala in 2002. While pursuing his medical studies in Trivandrum, he was inspired by the words of Swami Vivekananda. He had a deep desire to provide medical service to the poor and the needy in the remote villages of the country. Hence, even before graduating from college, he had decided to offer his services at such a rural setting once he was out of college. Once he completed his postgraduate studies in pediatrics, he reached Attappady to start medical relief work. The initial years of Attappady were spent in studying the community, especially the tribal people and their needs. A mobile medical unit was started in November 2002 with a few local boys to help in dispensing medicines. Along with the camps, he took the visit to tribal villages, many of them, met the people there, stayed in their houses, shared their food, and had discussions with them in terms of how to provide medical help for the tribal community. In this period of about 3 years, he worked to develop a mission which was close to their hearts and friendly to the needs of the people. And he never received any remuneration or any salary for the first few years of his work. And Swami Vivekananda Medical Mission was registered as a charitable trust in 2004. Going on from there, a number of things he has actually done over the years, and in addition to providing the basic medical help in various aspects of health camps and day-to-day practices, etc. He has also set up the village health worker program, which is involving volunteers from selected villages. He has volunteers from about 100 villages now. And their network and deliver programs of the mission to the villages. Obviously, mental illness is extremely common, and so they say, in the Attappady context. And many of the people may not be able to access psychiatrist help because of the costly exercise or because of the lack of awareness that they may actually have. So he started a solution to this complicated problem, a community mental health program was started in March 2009 in Attappady, with close cooperation of the Department of Psychiatry at the Trustee Medical College in Kerala. And he has since started a de-addiction program at the Swami Vivekananda Medical Mission Hospital in 2011 to combat the social evil of alcoholism, which was rampant among the tribes of Attappady. So the mission under the leadership of Dr. Narayanan is now actively involved in running two skill development centers in rural development program for the tribal villages. Under this program, the village committees have been formed in 100 villages. The village committees steer the development of work in villages through farming, livelihood generation, education resource centers, self-help groups, etc. Multiple projects for socioeconomic development of tribal communities are now progressing, like farming projects, projects for drinking water, toilets, and livelihood, etc. So it is indeed a pleasure to have you with us, Dr. Narayanan, and was pioneered this field from a general practice perspective, but he talks eloquently in terms of the issues that actually face tribal communities in Attappady. So you're very welcome to this discussion, and thank you very much for joining us in helping our ventures in terms of promoting literacy in tribal communities. So let me start the discussion with you, Dr. Narayanan. So you worked in Attappady since 2002. So can you sort of put us in context from your experience over the years, how mental illness and mental distress and whole issue of mental health problems is actually prevalent within the Attappady context, and also you may also make references to the other tribal communities in Kerala or in other Indian states as well. This will help us to actually try and get the discussion going in terms of the further challenges and other solutions that we want to explore.
Before answering your question, I'm very thankful to Dr. Raghu Raghavan and MeHeLP for giving me this opportunity. Am I audible?
Yes.
Yeah. So it's a wonderful opportunity actually discuss about our experiences there in Attappady. Coming to your question, we were actually we started with a general medical OP where people used to come with different ailments, medical problems, and we used to give them medicines, and mostly tribal patients were our we cater to most of the tribal populations all over the place. So when we started our practice and as it went on, we could see so many patients coming with problems of mental illness, many family members coming with problems of their relatives, husbands, wives, having mental issues. Like the wife coming and saying that my husband is suspecting me for so many things, and he's not sleeping, he's wandering around. Like that, we had several people coming to us with mental issues. As you had mentioned, we had this village health worker program, and the village health workers used to bring the stories of people having mental illness and not getting treated. They were roaming around. Like that, we had several people coming to us with problems of mental illness, but we were running this general medical OP, and we were not in a position to help them. There was at that point of time in 2003-4, there was no medical, that is mental health program in Attappady. The people had to go as far as Trishur Medical College or Kozhikode Medical College to access a psychiatrist help. And whenever the patient became violent, people used to actually board them on a jeep or some vehicle and take them to the medical college, and when the initial violent phase is over, then most of these patients are left to themselves uh, with no access to medicines, no access to, and once again, when the patient has to be transported all the way to Kozhikode or Thrissur again, uh, it 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 was a lot of expenses for the relatives, and so they used to leave the patient as they are, and the patients had chronic mental illness which was not being treated. So we when this problem was again and again brought to our notice, we were compelled to seek a solution. So I had actually sought an appointment with the head of the Department of Psychiatry in Thrissur Medical College, Dr. Shaji. Earlier, I had also discussed this with several psychiatrists whom I met, but how to actually provide this access to mental psychiatric treatment for these patients. So the problems were many. One was the access. The psychiatrist had to be seen at some 150 or 200 kilometers away, and the medicines were very costly. A month of medicines, psychiatric medicines, will cost something like 600, 700 rupees or 800 rupees, depending on the regime that they are being uh, treated with. So again, compliance, the patient had to be followed up. So number of issues were there. So when I met Dr. Shaji, the HOD of Thrissur Medical College, Psychiatry Department, I actually wanted to ask him to bring to send a psychiatrist from the psychiatry department to Attappady every now and then, so that we can start a treatment program. So he instantly refused the assistance. To my utter disappointment, he said, "No, there is nothing like that. No, nobody can send a psychiatrist from a medical college to a place like Attappady every week or every month." So that is a non-starter, because once the doctor decides that he is not traveling this far at any day, then your program stops there. So that was a, and immediately what he said was, if some one doctor, either you or somebody else, comes and uh, takes this up, I can actually provide you training, and this will become a very sustainable program, and your patients will have access to psychiatric treatment and medicines once you start this. So uh, in spite of the initial disappointment, I was actually um, uh, this motivated to go and take some training under Dr. Shaji, and I probably during my that is medical school, I was very much attracted to psychiatry, probably. But anyway, this was an opportunity which I used, and I went there. I spent 3 to 4 days there, and I used to follow up every month. I used to visit the psychiatry department. Used to take rounds with the professors there. So we had we wrote down a protocol: first line treatment, second line treatment, and when to refer, and all those things. A protocol was laid down, and that's how this mental health program which we are running now, that was how it started. So we went for the training in 2008, and we started it after 3 4 months. Slowly we started treating patients. We had to find the funds for the medicines. Initially there were no funds. Even now there is no what do you call a committed grant or sponsor for the program, but we have run the program for almost 10 years, 11 years now. So it has been a successful program by many parameters. So the treatment, that's how when we started looking at mental health, and um, providing access to mental patients from the tribal background, and improving access, improving literacy about mental illness. So all those things followed one by one. Then we started providing training programs to ground level workers, our village health workers, the workers of the government, the Kudumbashri, that is self-help groups, then other stakeholders in the community. So slowly we were having programs in which so many faculties from Medical College Thrissur and other places came, and they spoke about mental illness. And with each step, we could gather more patients, because all of these people who attended the training programs, they found out that their relatives, their neighbors, they had mental illness, and they brought them. The village health workers brought the patients. There was this instance when in a very remote place, which was a border with Tamil Nadu, almost 25 kilometers from Agli, from our center. There is a village where the village health worker, she herself brought 6 patients from the whole village, and that particular girl was actually that is appreciated by the whole village. She was treated as a hero, because she had she had brought the 6 patients, and all the 6 patients recovered. They no longer had mental illness, and that was something remarkable as far as the village people were concerned. So that was how our mental health work started, and it has progressed simultaneously by providing access, and on the other side by improving awareness about mental health.
Right. Thank you very much for that. I think that's an interesting start. And I think the way somebody that girl actually brought those 6 people to the clinic, and all of them recovered, must be a huge boost in relation to enabling people to understand about mental illness, and that it is actually treatable, that how the family need to look after one another, etc. So when going on from there, I think just to looking at sort of in the tribal communities, what are the kind of key issues? What are the kind of issues that actually prevents them from, apart from cost you mentioned and lack of awareness, but what are the other kind of things that might actually affect them in having no knowledge about mental illness, or in actually seeking help for mental illness?
Yeah, traditionally, as we know, any kind of rural community, especially the tribal people, they are very much prone to have superstitions, believing in magics and other things. So, whenever such things, when such symptoms come, they usually think that is somebody, some family member or some relative who is jealous of them, who has played some black magic, or like that. Some they have done some puja so that this person goes out of mind. So these kind of beliefs are really very rampant in the tribal community. So any rural community is very much susceptible to such kind of beliefs, and such a what do you call, a thought process, that anybody who is not sleeping well, or somebody who is getting sick due to any reason, would be a curse or some black magic by a relative or something like that. So these things are there. But to my very pleasant surprise and very happy experience, is that in Attappady, people have actually come forward with um, their patients, their relatives, for treatment whenever the mental illness, they identify it as a mental illness. So relatively, it has been very easy to get patients for treatment, unlike probably some other community, some other state or some other community, where you will have to actually go and fight with the relatives to get the patient treated. So many a times, I think the reward has been, or the impact has been, seeing other mentally ill patients getting treated. So it is a it is a very small community, almost 75,000 people all over Attappady. Though the area is large, people actually know each other very well. the relatives, the tribal community is well knit, and there is a very good network. So whenever somebody gets ill and he gets treated and he is walking around without symptoms, that is a very big advertisement for getting the mentally ill patients treated. So that has been a very good experience. So we see initially there were these people who said, no, no, this is black magic, or this is curse, or this is some that is that is um, the bad effects of something they have done in the past. So these things were there initially, but as time went on, as our program matured, we could see so many patients coming uh, instantly after 3 days or 4 days, or even just in a day. When the symptoms started, they were brought to the hospital, and immediately they were getting treatment. So these initial barriers were very easy to cross. Probably this may not be the same in other communities or in other states, where the cultural barriers are often very difficult to cross. And I often believe that, as I said, when people see somebody getting treated and they become symptom free, they are resuming their normal lives. There is nothing like no other advertisement or no other that is motivation to better motivation to get the mentally ill patients treated.
Yeah, yeah. And I think when we were in Attappady in February last year, we saw many women were actually, taking the lead in educating their families, their husbands, in relation to, getting away from alcohol and also seeking treatment, etc. So, do you think? What about the gender differences? What about the gender issues in relation to mental illness and mental distress in rural community, from your experience?
All over Kerala, wherever I have traveled to tribal villages, I have seen women taking the lead in all kinds of that is social life, in improving health, improving sanitation, improving conditions, improving livelihoods. Now, all of these women have been taking the lead, and in tribal communities, always we find the male population, they are going after alcohol, substance abuse, or some other ways of entertaining them, spending money, and all those things. But women are always on the that is leading the community in taking them forward in terms of medical treatment or other social improvement. So here also we see in alcohol addiction, in that is generating awareness on mental health. As I said, the village health workers themselves, a majority of them are women, and they have done real wonderful work, and in generating awareness, in getting patients for treatment. I remember one particular incident when a patient was brought to the hospital, not in our hospital, the government hospital, at midnight, and not with mental illness, some medical complaint. He had acute medical illness, and this village health worker had actually motivated the people to take a vehicle and bring them to the hospital, and she had come along with them. And the doctor was asking her, what is your work? Why you have come with them? Are you a relative? No, she said, I am a village health worker, that is working with the volunteer for Swami Vivekananda Medical Mission. And the doctor had asked, how much do you get paid for this work? And she said, no, no, I am a volunteer, and I'm doing this for my village, for my people. So that was something very surprising to the doctor himself, and that gives us immense pleasure in actually pursuing this work, where volunteers actually take this up as a very noble thing to do in their lives. So women have actually really done wonderful work in this particular program.
Yeah, thank you. I think that is very nice to hear, in terms of, I think, the women leading that work and then actually creating that transformation in the villages. Because when we went there, we met many health workers who are actually women, and they were actually trying to promote the primary healthcare work, and also the mental health literacy stuff as well. So, but in the past, people used to say that do people in tribal communities, do they understand about mental illness? Do they have a terminology for mental illness? So in my younger days and also my professional days, people often taught that that there isn't any word for that. So when we were there, we did actually speak to some older women in that community, and there's a word calls it manovishamam. And manovishamam is a common terminology in all in the whole of Kerala, and also in some other languages as well. So obviously there is a terminology, that there is an awareness of mental distress in the community. So how can we what are the ways in which we can promote mental health literacy in tribal community?
From our experience, actually engaging with the community stakeholders in various forms, engaging with them, providing them awareness, giving them our experience, giving them a feedback of our experience in the mental health program, and explaining to them what has been done in the recent past and what can be done. That helps a lot in improving literacy, mental health literacy. Uh, Whenever we have been conducting programs, that is awareness programs with various sections, whether it is self-help groups, whether it is village health workers, whether it is the government health staff like ASHA workers or junior public health nurses, or any kind of that is segments, we find that immediately after the program, we find a number of patients being added to our program. So whenever we give the message, immediately the Kudumbashree workers or the ASHA workers suddenly find, yeah, this lady has to be treated. She will get good treatment here. And immediately they take the pains to catch hold of the patient and then convince the relatives, and then bring them to the hospital. We usually we are following a volunteer-based network to support this program, and it is like we tag for each patient, we tag a close neighbor or a shop person running a shop nearby, or a Anganwadi teacher, like that, any one worker who is interested to support the patient. So that particular volunteer will come and support the patient in that, like whether they are taking the medicines properly, whether they are improving, the symptoms are improving. Like that, different aspects of the patient care is supported by these volunteers. And that volunteer, when they are empowered, when they are given information about mental illness and what turn it can take and how long the patient has to take medicines, eventually what is going to happen, and when the patient is getting better, there is a chance for relapse, and maybe after a year or after 2 years, there is a chance for relapse. So these things are actually the family member is looking after that, and simultaneously it is being looked after by a volunteer who is a neighbor or somebody who is living nearby, or a government staff, or some even our own village health worker. So while they are doing this, they'll immediately find another patient who has the same symptoms or similar symptoms, and they are, because they are empowered, they'll identify that patient as a mentally ill patient, and then they will advise the other family also, that see that the other patient has got better. Now you have to get treated, and definitely this treatment will be effective. So like that, the empowering the ground level workers has given us a lot of it has been a golden harvest for us. So that has given immense impact on the ground. So actually, uh, more than the psychosis anybody can, um, because of the frank symptoms or because of the very outward symptoms, people will suddenly immediately identify it as a very uh, severe mental illness. And today or tomorrow, when the violent, when the symptoms are precipitated and when they go overboard, somebody or the other has to actually take these patients to the hospital or the mental illness facility, the treatment facility. But the difficult part is regarding the depression or anxiety, where the patients actually experience the symptoms. They are in a very bad situation where they cannot identify these as mental illness problems. They have headache, they have chest pain, they have abdominal pain, they have vomiting sensation, they have poor appetite, they have poor sleep, and they go from one doctor to the another, and finally they are in a very bad situation, very morbid condition. So when we teach these ground level workers, and when we teach the common people that these are these symptoms are related to depression, and these symptoms can be treated with medical treatment, and these are effectively managed. And we have several patients who have been treated, and they have come out, and they are really doing well. So that message, when we give it to the very ground level workers like village health workers or ASHA workers or the Kudumbashri workers, that gives a very big impact. And we find patients coming, the volunteers themselves, they are saying that, doctor, I think this patient has depression. She's not eating well. She's crying. So these empowering the ground level workers is a key to the creating mental health literacy, and the rewards are immense. The rewards are we cannot describe the rewards, because that has actually paid us back very much.
Okay, yeah. Thank you for that. I think you have one unique advantage in your work. Obviously, you're a general practitioner, and obviously there is no stigma in coming to you. Because obviously, it's not like going to a psychiatrist or the local government mental health hospital setting, because there is no stigma. You're actually just seeing a general practitioner. So how does that kind of a model, because such a model might actually work in many urban communities where there is stigma around things, and then go and see a general practitioner for mental illness and receive treatment through that. So how does that general practitioner model for mental illness work within the tribe?
Yeah, that's a very good question and a very good one to answer also, because uh, being a general practitioner gives me, or any general practitioner, a very three or four advantages. One is we see so many patients from the same family repeatedly. So we have been seeing a person for the last 5 or 6 years, and we suddenly see their wife or mother or children, all of them one after the other at some point of time, and we are very much familiar with their backgrounds, familiar with their past symptoms, medical history, and so we have a very good awareness of what is happening in the family over the last 5 or 10 years or 15 years. So that gives us a very big advantage of identifying the problem immediately when they come with the symptoms or their complaints. So that is one thing, because the patient comes with chest pain. Dr. Shaji, HOD in Thrissur Medical College, he was the one who told me that being a general practitioner, you should be, apart from treating the psychosis, you should be able to identify the anxiety disorders, the OCDs, the depressions, and other such symptoms in the normal patient, supposedly normal patient coming to you with somatic symptoms. So we very often see patients with chest pain, with breathing difficulty, uh, and like a number of symptoms, which even there, he or she will be already a cardiac patient, they will be already a diabetic patient, already they may be having asthma, but this particular breathlessness may not be attributable to their that is physical illness. I have a particular one girl, 14-year girl who has asthma. She comes with asthma every month, but in between she comes with breathlessness without asthmatic symptoms. That is asthmatic signs. So when we treat, she today she comes with breathlessness. Tomorrow again she comes back with breathlessness. And when we discuss, we find that she has some mental issues, some anxiety problems, which she is actually copying her regular physical symptoms to the to her regular condition. So this particular thing is identifiable by a general practitioners because you see the patient very regularly. So that is one advantage the general practitioner has. Secondly, as you said, the stigma part. So many patients will know that I am small inside that I have a mental illness, but going to a psychiatrist is unthinkable or kind of that's a big barrier they have to cross. Going to a psychiatrist, no, I cannot go and see a psychiatrist. They will give some medicines to sleep, and then I am going to be dependent on them, dependent on the psychiatric medicines. All those things, all those thoughts. Uh, Actually prevent the patients from going to a psychiatrist and sitting there. Somebody will see us sitting in front of a psychiatrist OP, and they'll ask why you are here. uh, you have some mental illness. So these stigma issues actually are not there when they come to the general practitioner. Third, um, they see the patient very regularly. Even the patient with mental illness comes there with headache, comes there with urinary infection, comes there with other infections. So you have a very good chance of following them up in the coming period. Even if even if your medicines have some side effects, they are immediately coming back to you because you have a long-standing relationship, regular feedback mechanism, and most important, they have ultimate faith in the general practitioner who is the regular that is doctor of the family. So that comes with a lot of advantages. So, for a general practitioner to practice mental health treatment, it gives a lot of advantages to the patient as well as to the doctor. And fourth thing is the access. Because psychiatrists are available by appointment. They have fixed hours. So the general practitioner is readily available. He can actually pat on your shoulder and say, no, this is okay, don't worry. So all these extra bits add to the real medical treatment, that is the efficacy of the that is psychiatric treatment that the patient is getting. So that puts the medical general practitioners to a very big advantage. So actually, I have repeatedly over the years thanked Dr. Shaji for putting this into me, and I even feel that I have got some divine that is some
Yes.
skills, so that patients when they come with chest pain, I identify, no, this is not chest pain, this is anxiety disorder. When they say the palpitation, I immediately ask whether you have good sleep. So you have gained some other knowledge which the regular doctors don't have. Like that, some a divine thing has come to me. So I start treating patients which other doctors are not able to treat. So these kind of things add a lot to the general practitioners' support base and their goodwill in the community and all those things. So whenever for each of your problems, the general practitioner has an answer.
Yeah.
Yeah, so that adds to the goodwill from the in the community.
Okay. Thank you for that. I think that's interesting because obviously that closeness, the connection, access to services, and also the general know-how, because knowing the people, the community, and all those things actually helps, which is actually very much of an advantageous position in the community, really, because as a community leader, as a community doctor, and all those kind of perspectives, it's actually quite helpful. We have quite a few questions that's come up. Let me just take them one after the other. From the first question is actually from Dr. Trinchna Katal, I think I'm saying the name correctly, is asking about sharing the tips on how we can empower layperson and how to intervene and convince the sufferer to seek professional help.
Actually, I have covered that part in what I have said so far. I'll maybe put it in a different way. Uh, the people who are around the patient, mentally ill patient, they are the one who have to convince or motivate the patient to seek help. So it may be somebody with a substance abuse condition, somebody with an alcohol addiction, or some depression. So usually people with depression will say, no, 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 I'm not going anywhere. This is my fate. I'll suffer this in silence and all those things. So the patient, the persons around them, it may be the family member, or a close relative, or some teacher, or some postman, or a business person, or a person running a shop, or a government health worker, or an Anganwadi teacher. Like that, there are so many kinds of people, the ward member, the Asha, so many people are there who are bound to come in contact with the person, and then so our creating mental health literacy has to be a continuous work. You do some work and then stop there and then go after the treatment aspect. Then that connect is lost. Actually, it has to be a continuous work. Every year you have to any person or NGO or some institution engaged in this mental health that process, mental health treatment, has to actually engage in empowering the community on a regular basis. So there may be uh, in a particular ward, there may be 1,500 people or 2,000 people, 2,500 people. You may not cover the whole of the ward in one sitting or one program. So you catch all of the key persons there, and you treat them, then cover one by one. Even in any palliative care, in cancer care, everything the same thing has to come actually, for people to gain awareness of cancer, to identify one particular thing as one particular symptom as a cancerous symptom. Actually, they have to gain awareness. So again, in mental health also, this is the same thing is applicable. So you have to ward by ward or village by village, we have to identify the key persons, the educated people, the influential people, and the process of awareness creation has to be a continuous affair. uh, the methods can be multiple. That is, as Raghu
Yeah.
sir has been saying here, they had conducted theater workshops, theater interactions with patients, relatives. It can be in the form of social media. It can be in the form of a focus group discussion.
Yeah.
Then educating the youth, the high school students, college students, they have a lot of mental issues. Adolescents have a lot of mental issues. So we when we discuss with college students, we usually find that their peer groups there will be somebody in the peer group having a suicidal tendencies, substance
Yeah.
uh, addiction, all those. So we have to catch hold of each section of the community and continuously have a program of generating this awareness. So that is how I think it is. You cannot say I have done it and then sit back and say that everybody has awareness, so my job is done. So it has to be a continuous job. Today somebody would have heard it, but they would not have registered it. Next time around, they may be registering it properly, and
Yeah.
suddenly they may be seeing one patient and then think that doctor was saying something about this. Let us go and ask them. So like that, it is a continuous process. It is never
Yeah.
one stop program.
Yes. Yeah. I remember when we were there, when our theatre engagement in last February created a major immediate impact in some of the families, really. And they were taking medicines and they were seeking help. They were coming to you and they were actually self-caring for themselves, and all those things actually happened, immediate impact, which we never thought that might actually happen. And I sort of believe that some of those theatre and other creative methods of intervention might very much work within the rural and tribal communities. We just take it to another question from Dr. Ramkumar in Secretary from Idukki district. talks about, some say there are less family ties in tribal community. And hence, if a person wanders away due to the mental illness, the chances are that the person will wander in the forest with less chance of being chased by anybody. And sometimes a wandered person who leaves the community never is actually accepted back. So his question is, how do we integrate such people with family when there is abandonment, especially in the case of women?
Yeah, the one particular incident that comes to our mind is that of Madhu. Everybody would have known about it. 2 years back, Madhu was a psychiatric patient who had wandered away. He was living in a cave, and he used to come out in nights during nights and collect provisions for his own use. So people, the shopkeepers used to find a lot of their material being stolen, provisions, rice and other things being stolen. And finally, when they caught hold of him, some of them had some real aggression, and finally that ended up with Madhu being killed by the gathering. So it was actually this Madhu had lost connection with his family, and he was living far away, almost 10-15 kilometers away in a cave. So what you asked is a very, very relevant thing. Uh, but the first part of the question, you had mentioned that that is tribal communities have less of family ties, which I think is not true. Uh, Probably in the current generation, they are losing that network among families. Tribal families are usually what I've seen in Wayanad and what I've seen in Attappady. They are actually well knit. They have a very good network, and they actually know generations. That is all the networks far away. They identify people saying that he is my relative, he is my brother-in-law. Brother-in-law, in the sense, he would have been some sister's husband, some distant cousin's husband, like that. They identify people, saying he's my uncle and he's my grandfather, like that. People identify long distance relatives very much. They are well connected. They gather around for funerals, marriages, other family functions. And if they don't come, they are actually, as you said, they are cast away. You are not permitted to enter again. So usually people keep their connections well oiled and well knit whenever it is possible. Uh, that is a traditional tribal family that I am speaking about. In the last 10-15 years or 20 years, the modernity has actually harmed a lot of these connections, and even inside the village, uh, people actually care for each other. Whenever somebody has no relations, some old man is left um, unattended to, that is from the family, the children are not there. Traditionally, the tribal families go around and take care of them, give them food, support them, and whenever these old people are fed, after that the other nearby families eat, even if there is no actual relation. Also, they do that. But in the recent past, we feel that those kind of very close community links have been affected, and people kind of tend to ignore such ties, such relationships, and they are more towards looking after themselves. What we feel is the curse of modernity wherever we are in the world. Though these community ties are not attended to, they are not cared for, and we feel that even brothers, sisters, they don't talk to each other very often. The close relations don't talk, that we find all over the world. In the modern life has given us that particular situation. So this is there in the tribal community also. So um, the tribal mindset is, they don't look forward. That is, in the sense, they don't they don't think about what is going to happen tomorrow or next week or the next year. They don't plan for their lives. They take it as it comes, and that is a traditional tribal mindset. uh, So whatever happens, they take it in their stride. They don't bother. They don't save for their future. They don't plan for their future. This is what I'm saying is when somebody gets sick or somebody has some problem, the community is there to look after them. That is a historical uh, that is experience.
Yeah.
So when these ties don't work, when these connections don't work, when these networks don't work, when somebody has a problem, he has no one else to look after. He has to take care of himself, and he has to plan for that. He has to attend to that himself, which is actually very, which is a very mountainous task. It is a very tall order for a ordinary tribal person. This is something that they have actually entered modernity, but they have not learned from modernity. They are not ready for modernity. So these reduced networking, reduced communal or community backup is really frightening for them. Many of them, they cannot face the world alone when they are in crisis or something, which is something which leads to mental illness many times. The particular question that you had asked is, if somebody goes away, how do you find them? It is really tough actually when somebody is wandering, catching hold of them. We know particularly 4 or 5 patients who have never been rehabilitated because they have been wandering for so long. And once we treat them, and then when we after the treatment, when we discharge them, we again find them wandering, not going back to their families and other things. Generally, uh, on the rehabilitation aspect, generally we have about 200 patients whom we have treated, and most of them uh, immediately when we treat them, immediately they go back to work. They are rehabilitated with their families. They are looked after by the families. So all those things are normally, that is in the majority of patients that is happening. But in a very small minority, when they actually go off the tangent, it's very difficult to manage them. It is we need really a big team of support systems to actually catch hold of them and bring them back.
Yeah. Okay. Yeah. Another question. Thank you for that. I think another question is actually about, from Gaudo Saxena, looking at the notion of mental health among tribal people. Is it different from the notion of mental health in the general population?
I am not very sure whether I am qualified to answer that, because I have not treated uh, patients a lot away from the tribal community. I have a lot of patients who are not in the tribal community, psychiatric patients. So because basically I'm not a psychiatrist. Uh, so whenever we see patients are getting treated immediately after they get the symptoms, we see very good that is remission. We see very good um, improvement of symptoms, and they are very less likely to have a um, that is scar of the disease and the normal lives later on. That is what I have seen as a general experience that I am
Mhm.
seeing. That is, whenever the patients come before 1 month or 2 months of getting the symptoms, and then we treat them, they go back normal, without any symptoms, and they are very easily they resume their normal occupations, their regular work. They don't forget their skills. They don't forget what they have learned in the past. All those things we see. That is true in both tribal and non-tribal patients. I have heard doctors saying, psychiatrists saying that many patients from Attappady, when they come, they very easily respond to symptoms, respond to treatment, and the chronic schizophrenia or bipolar disorder patients from the general community, they don't respond that much to the medical treatment like these tribal patients. These are some comments I have heard from doctors, senior doctors, psychiatrists who are working in medical colleges and other places. As far as I know, as far as I have seen, I don't think there is any big difference. The early they come, the better they are. That is what I feel.
Okay. Thank you for that. I think that's interesting. And from your opinion, what are the kind of challenges that the tribal communities working in the tribal community may not be everybody's cup of tea? So how do you, your experience that you can share in just promoting mental health literacy in the tribal community? What are kind of the challenges that Kerala faces and also India faces in terms of serving the tribal community?
Broadly, when we work in the tribal community, gaining their goodwill or their acceptance is the biggest challenge any doctor or any social worker will face. So we actually went through that phase in the maybe for first 5 or 6 years. We had to gain their trust and acceptance, and they should believe that your intentions are not to gain other benefits out of this. So those barriers we had to cross. Uh, there are a lot of NGOs, there are a lot of government schemes, there are a lot of government workers working in the tribal sector. And in Attappady, especially, we find a lot of people going in the tribal villages and interacting with them, conducting surveys, conducting awareness classes. So this has been a very day-to-day affair for most of the tribal people, and they are actually very much numbed or actually resistant to what people come and say about anything, whether it is sanitation or hygiene or nutrition or any kind of intervention. When people come and say, they will immediately say, "Yo, you are getting some funds, and you want to use your funds, and you are using our situations, tribal background to gain those funds." So these skepticism is very much relevant, very much that is prevalent in tribal communities, especially in Attappady. So what we have been able to do is we have been able to go again and again and repeated work repeated work without any other that is advantage, that is or some other benefits which we intend to gain from that. Only the that is ground level transformation that we are aiming at. So these things have been understood by the tribal community over a period of time. Not that they immediately understand what you are going to do or immediately recognize who is going to do. A lot of people have gone and actually that is exploited the tribal people in the name of projects and other schemes, which has left a very bad impact on the or impression on the tribal people. So this is a big barrier. And secondly, the tribal volunteers, the tribal people have a lot of they have received a lot of monetary benefits, lot of uh, schemes have given them subsidies, uh, like that. People have become used to gaining benefits without their own initiative. So
Yeah.
you join our project and you will get some money. So like that, volunteers are used to getting money for no work. So that is one other side effect of this NGO culture, which also we had to actually cross or jump the hurdle for getting some volunteers to work for the real motivation. It took some years. Took 5 6 years or even 10 years to get that kind of volunteers who will actually understand the subject and work for the cause rather than work for some petty money that they are going to receive. It took some time, but now, as I said, as the incident I had described earlier, many people are there many young women and men are there who would really come out and work for the village, that is common good of the village. Either it is in mental health or in other social sectors. They are prepared to, that is, go the extra yard for the common cause. So these are some hurdles which we had to actually really cross to work in the tribal villages.
Yeah. I think that's great statement in terms of, because it's showing your commitment and the kind of unconditional positive regard for the community in terms of, with no vested interest in, and also able to, equip and train the volunteers and trying to motivate them on a daily basis in terms of we have to serve the community. That is a severe, huge challenge. And I think you kind of overcome, I'm sure there are struggles and there are challenges ahead, but I think there are some basic things that you have actually overcome in the model of the services that you try and provide, which I think it is exemplary and a pioneering piece of work. And I think it must be very much applauded, very much applauded. So, because I think it is an example of how, collectively, some initiatives and collectively, yeah, you could actually make transformations in communities through volunteering, through commitment, through social network, and a number of other wider socio-cultural initiatives as well. Because I think mental illness is not just the symptomatology of things. Really, it is the wider social, cultural, and religious connotation, which I think is very much true in the tribal community. So we must actually have a cultural appropriate model of in terms of how we approach mental illness and how we provide help and support for those communities. That is very, very important. Any further questions from anybody in the audience? Any further comments or questions that you may wish to raise? This is very much of an interactive session, so obviously you're welcome to raise any further questions or comments. Okay, so I think it's been an eye opener for me, even though we have known each other for a bit of times over the last couple of years in terms of the services that you provide. So I think it has been an eye opener for me how things are actually being dealt with, and how we are actually constantly innovating things in terms of how things could be provided. We have one further question. How do we sustain funding for such projects for continued efforts, and also what are the impact indicators? This is from Dr. Chinchna, Qatar.
I'm not sure I know the answer for that, because sustaining funding is a big question, which for our program, it has been 11 years old, and we don't have a proper funding for the program. We run the hospital and other institutions, and we actually cross subsidize whatever we get from the hospital or other projects, and use it for the mental health project. There are, I think, some granting agencies now which actually take up mental health in a big way. That is what I understand, and we are pursuing those. But generally, apart from those agencies, mental health is not very that is the go-to projects for the regular funding agencies. They don't. They are actually afraid, or even this also has a stigma. This particular project also has a stigma as a regular funding option. Some Tata Trust or Asimbranji or some regular agencies are, some few agencies are there who take up mental health in a big way and support mental health. Otherwise, we find very few people are supporting mental health in that sense.
Are there any government schemes? That's one of the questions again. Are there any government scheme in relation to mental health issues in tribal community?
Actually, the mental health program, district national mental health program itself is a very big program, but it doesn't incorporate private or that is agencies from the NGO sector. It is fully funded by the government. It is a huge program which is run at the district level, and that doesn't incorporate other agencies. So government funding is mainly for the mental health. It's mainly through the National Mental Health Program, MHP.
Okay. Okay. Right, I think we've sort of covered a lot of ground in relation to the contextualization of mental health and mental distress in Attappady within the tribal context, and the kind of help and support services that you offer, and the unique model, the general practice model in mental health is actually a wonderful model. And I admire that because there is no stigma attached to it. And I think, and also the social connectedness with those communities, the families, and the number of other programs that actually happen concurrently with the health mission. They're all to be applauded. And I think it's a huge mission, it's a huge task. And I think, I take my hats off to you for all this effort. And over the years, I think you actually worked tirelessly to actually achieve this. And I'm sure there are more challenges that would actually face, but I think it is a huge effort and making an impact, huge impact in the community. It is no simple task at all. It is a great, great task, and I think not many people would do that. And I think that must be said. So we are nearly an hour and a quarter of discussion. So if there are no further questions, then I would like to round this up. Excellent discussion. Thank you very much for coming on board. And it's been a great pleasure to link with you, Dr. Narayanan, over the last couple of years. And we hope to continue our collaboration with you through the project and other means with you and the health mission. And I think, we with this project and also with follow-on projects that might actually follow this, it'll be a great pleasure to work with you and have your inspiration, your insight, and your connectedness, most importantly, with the families and the health workers, which I've actually seen from firsthand, going to some of those rural communities, and I think it's wonderful. And it's a great joy to actually see some of those things, really, how the link workers actually work with the communities, the kind of resourcefulness they actually have, etc. So it's been a wonderful experience for us to link with you and the project, and a heartfelt thanks to you and for the health mission. And hopefully, we will be in touch soon in relation to how we take our project to the next levels in the Attappady context. Thank you very much indeed. So, and also thank you to all the participants for spending your valuable time in discussing this important topic. My mission is actually to get everybody to talk about mental health, and in the Kerala context, and I want 36 million people to talk about mental health and mental illness, and the Indian context as well. So obviously, I think quality is actually important, and the kind of questions that you have actually posed is very important to us, and that I hope that we have continued engagement from you in our webinars, and also try and create a kind of a community of practice, a community of specialists or professionals who are actually interested in it, and are actually able to talk and help each other in relation to promoting mental health literacy. Mental health literacy is not just mental health awareness. Mental health literacy is more than just an awareness. It is actually enabling the person to understand what is mental illness, enabling the families, enabling and to seek help, and enabling to understand and seek more information in relation to what is mental health and how we can actually work with those communities, and also to enable the government to understand the plight of some of those communities and to seek help, and to actually applaud the work of NGOs in this field. So thank you very much, Dr. Narayanan, for once again for coming on board and spending your valuable time with us. And I also wish to thank Parvati, our digital consultant, for hosting this webinar for MeHeLP India. Thank you very much, and have a good evening from the UK, and also for a good evening from India.